Good day everyone. So for this video, we will be presenting our case study about epilepsy. This is prepared by yours truly and Maria Angela Del Gallego. So this will be our flow of discussion from pathophysiology of the disease until the rationale for recommendation. Let's first discuss the pathophysiology of the disease. So as we can see in this slide, there is a transmitting message and a receiving neuron. So on this left side, there is a transmitting message that is negative and it has a GABA inhibitory. On the right side, there is a transmitting message that is positive which has a glutamate or excitatory. So, epilepsy is due to a sudden, uncontrolled depolarization of neurons, resulting in abnormal motor or sensory activity with or without loss of consciousness, according to Van Meter and Hubert in 2014. Also, according to Spray in 2013, epilepsy results from imbalance between neuronal excitation and inhibition, which arise from hyperexcitation and hypersynchronization of a neuronal network. So some of the factors that may trigger epilepsy in some people include physical stimuli. For example, yung loud noise, bright light, or biochemical stimuli such as excessive fluid retention, hypoglycemia, change in medication, alkalosis, sudden withdrawal from sedatives, and alcohol. So the immediate period following an epileptic seizure is regarded as a postictal state, and this can include signs of headache, confusion, dysphagia, memory loss, short-term paralysis, or deep sleep. This is according to Kerr-Weather and Narayanan in 2017. Next is the signs and symptoms of epilepsy. First one is the convulsion without temperature. So yung kinukumbulsyon. Next is blackout or loss of consciousness, yung nahihimatay. Next is sudden stiffness of the body, so naninigas. And then the sudden bouts of blinking, yun yung napapapikit kahit um, involuntary siya. Uncontrollable jerking movements of the extremities, ito yung katulad nasa picture is yung kamay is naninigas din talaga siya and yung mga extremities nanginginig kapag in epilepsy, 'di ba? Nangingisay. Next is fear and anxiety. Strange sensations such as a rising feeling in the tummy, unusual smells or tastes, and a tingling feeling in your arms or legs. Next is extreme weakness of muscles, so nanghihina din. Next is the complications of epilepsy. First one is the difficulty learning. Next is breathing in food or saliva into the lungs during a seizure, which can cause aspiration pneumonia. So, kumbaga, kapag yung saliva during these episodes, napupunta siya sa lungs. So, nagkakos siya ng aspiration pneumonia. Next is injury from falls, bumps, self-inflicted bites, driving or operating machinery during a seizure. So, syempre, dahil nahihimatay and nangingisay during epilepsy, nagkakaroon din ng injuries. And pwede din ma-aksidente. Next is permanent brain damage, which is stroke or other damage. So, dahil sa neurons and sa brain din to, kaya nagkakaroon siya ng complications sa brain damage. Pwede, possible siya. Next is side effects of medicine. So dahil neurological and psychotic yung mga drugs na binibigay dito is there are times na magkakaroon ng side effects. So this is our clinical guideline. So this is the link entitled Epilepsies, Diagnosis and Management by NICE Clinical Guidelines number 137 from May 12, 2021. And these are the results of our agree to tool from the six domains. So these are the total scores, and the overall score is 82.03%.
Now let's discuss our case on epilepsy. So the patient was a 27-year-old woman who was first diagnosed with partial complex seizures at the age of 7. Despite multiple trials of various anti-epileptic drugs, the seizures were difficult to control. At age 20, her seizures changed in character. She was experiencing multiple daily episodes of left-sided face, arm and leg twitching without impairment of consciousness, and she also developed a slowly progressive left-sided weakness. She had multiple hospitalizations for focal motor status epilepticus. Her past medical history was remarkable for asthma and depression. She had a normal early childhood with no history of febrile seizures, meningoencephalitis, or head trauma. She graduated from high school and worked as a nursing assistant but was forced to quit due to her seizures. Her family history was non-contributory. So now let's discuss the SOAP analysis. For first, subjective informations. The patient was a 27-year-old woman who was diagnosed with partial complex seizures when she was 7 years old. The seizures were difficult to control despite many trials of various anti-epileptic medicines. Her seizures changed in type when she was in 20. She was having many daily episodes of left-sided face, facial, arm, and leg twitching without losing consciousness, and she was also developing a slowly progressing left-sided weakening. So, for the objective information, neurological examination upon a recent hospital admission showed episode of left facial twitching every 5 minutes. The examination of higher mental function. So, examination of higher mental function showed dyscalculia and possible left neglect. Her memory orientation to place, a person, and time were intact. The cranial nerve examination was significant for left homonymous hemanopia and mild left facial droop. The motor coordination was poor bilaterally and her gait was very unsteady. The neuroimaging studies were performed and the results compared to the previous studies and showed progressive right hemispheric atrophy and contralateral cerebellar atrophy. And lastly, a biopsy of the right temporal lobe tip was performed and showed marked gliosis and neural loss and focal perivascular and intraparenchymal lymphocytic infiltrates. So for the primary impression, the MRI examination shows hemiatrophy with ipsilateral ventricular dilation. The proton density and T2 weighted images may shows area of high intensity signal in the white matter. The pathological examination shows the chronic encephalitis confined to one hemisphere. So, in the active phase, neuron of phagia activated microglial cells or the rod cells and the microglial nodules and the perivascular lymphocytic infiltrates are present. In the more chronic phase, neuronal the neuronal loss and the gliosis predominate. The pathological picture, although typical for chronic encephalitis, is non-specific. The distribution of the changes, however, with the inclusive involvement of one hemisphere, is typical for Rasmussen's encephalitis. So now let's discuss the list of patient symptoms with treatment goals. So for the symptoms and signs, the patient was experiencing multiple daily episodes of left-sided face, arm, and leg twitching without impairment of consciousness, and she also developed a slowly progressive left-sided weakening. So the goal of treating patient with epilepsy is to control seizures completely without causing unacceptable side effects. So now let's discuss the plan. So for the list of the possible solutions, the treatment of choice is functionally complete hemispherectomy with complete disconnection of the frontal and the occipital lobe. Next is implementing the AED treatment strategy, and we recommend the patient to take the buccal midazolam and the rectal diazepam. And now let's discuss the drug interactions in this case. So now let's discuss the drug interaction of midazolam. It decreased the plasma concentration with CYP3A4 inducers. Example given are rifampicin, carbamazepine, and the phenytoin. The potentiate they potentiate the action of antipsychotic barbiturates, prop, propofol, ketamine, sedative antidepressants, antihistamine, and centrally acting antihypertensive drugs. It is potentially fetal because it increased the plasma concentration with CYP3A4 inhibitors. Examples are the ketoconazole, the itraconazole, voriconazole, clarithromycin, telithromycin, boceprevir, the nefaz- nefazodone. It also increased the risk of profound sedation, respiratory depression, coma, and death with op- opioids. Example given are morphine, meperidine, and the fentanyl. So for the drug interaction of diazepam, it potentiated effects with other centrally acting agents like antipsychotics, anxiolytics, anticonvulsants, antihistamines, the MAO inhibitors, antiaesthetics, and barbiturates. Enhanced sedative effect with other drugs such as lofexidine, nabilone, and disulfiram. It also reduces the clearance and potentiate action with the CYP3A4 inhibitors like cimetidine, isoniazid, erythromycin, omeprazole, and ketoconazole. It also increased metabolism and clearance with CYP3A4 inducers like rifampicin, carbamazepine, and the phenytoin. It also antagonized effect with theophylline, delayed absorption with antacids. It is also fetal because the concomitant use with opioids may result in sedation, respiratory depression, coma, and death. It also increased the prolonged sedation with pseudovodidine pseudovodidine it may also enhance the CNS depressant effect of sodium oxybate. So for the last part of our presentation, let's discuss the rationale for our recommendation. So for our first recommendation, we recommended um, the hemispherectomy with complete disconnection of the frontal and the occipital lobe because this surgery still remains the only cure for the seizures caused by the Rasmussen's encephalitis. The homonymous hemianopia and the hemiplegia are inevitable, although both might be present before surgery. The rehabilitation to independent walking is expected, although fine motor movement in the hand on the affected side is not. The small resection can sometimes be preferable to preserve function, but no investigators have reported sustained seizure freedom after limited resection in patient with Rasmussen encephalitis. The hemispherectomy offers one of the best chances of making patient with Rasmussen's encephalitis seizure free. 70 to 80% long-term seizures free outcome. So the decision in older children and adults can be more difficult if the disease affects the dominant hemisphere. So for the seizures of the patient, we recommend to take buccal midazolam and the rectal diazepam because according to the clinical guidelines that we found, It is stated there that the only prescribed buccal midazolam or rectal diazepam for use in the community for children, young people, and adults who have a previous episode of prolonged or serial convulsive seizures. It is also stated there to administer buccal midazolam in first-line treatment in children, young people, and adults with prolonged or repeated seizures in the community. Administer rectal diazepam if if preferred or buccal midazolam is not available. We can also use intravenous lorazepam if intravenous access is already established and resuscitation facilities are available. So the last one is we recommend to implement the AED treatment strategy. So the AED or the anti-epileptic drug treatment strategy should be individualized according to the seizure type, epilepsy syndrome, co-medication and comorbidity, the child, young person, or adult's lifestyle, and the preferences of the person, their family, and or the carers as appropriate. So, because despite taking the several anti-epileptic medication, the patient still experience symptoms because aside from epilepsy, the patient has an underlying disease which is the Rasmussen's encephalitis that is characterized by intractable seizures. So we go we will go back to the first with our first recommendation, which is the surgery, because it still remains the only cure for the seizure caused by the Rasmussen encephalitis. So now let's discuss the therapy specific variables. First medication is midazolam. So its dosage form is usually 2 to 2.5 milligrams. It is given at a rate of 2 mg per minute or 5 to 10 minutes before procedure. The duration of the therapy it is until the desired endpoint is achieved. So the least possible side effects of the midazolam are headache, drowsiness, nausea, vomiting, hiccups, coughing, pain, redness, or hardening of the skin at the injection site. So sign that midazolam is not working. So if it's not working, consult your doctor. You may have another problem that necessitates the use of the prescription medication. So for the counseling points, development of tolerance and the requirement for a higher doses may occur with prolonged use. So withdraw slowly after prolonged use to avoid precipitating rebound seizures. Prolonged use may result in the neonatal abstinence syndrome. So for our last drug, let's discuss diazepam. Its dosage form is usually zero point 0.5 milligrams or kilograms. And its maximum dosage is 30 milligrams or kilograms. So the dose and the dosing interval frequency is 4 hours. The duration of therapy until it is needed, and the list of possible side effects of diazepam are drowsiness, confusion, problem with your coordination or controlling your movements, or tremors. Signs that diazepam is not working if the medication does not relieve your symptoms. So for the counseling points, this drug may cause CNS depression, uh, like sedation, amnesia, impaired concentration, dizziness, and drowsiness, blurred vision, and impaired muscular function. If affected, do not drive or operate machinery. And lastly, here are the references that we used to make this presentation. Thank you for listening.